Usually in the patients, if you see, up to the anterior 2/3 it's almost flat. Posterior 1/3 is raising up like this. So if you are going to extend it up to the posterior 1/3, it will act as an inclined plane and push the denture down. So it will affect your stability of the denture. So if you want stability of your denture, it has to stop up to the anterior 2/3 of the retromolar pad. So retromolar pad is important for retention, stability as well as support. Labial frenum, you have fibrous connective tissue and also muscles of orbicularis oris. Usually a single narrow band. That's the labial frenum. Sometimes you can have additional attachments also. So how do you actually give relief for this frenum in the denture? Carborundum disc. At which stage? Denture delivery. Before that you don't look for the frenum. Which stage you will look for the frenum? Secondary impression. Before secondary impression? So you have to record your frenum properly in your primary impression. Only when we miss that, it doesn't get recorded in your cast. So you will naturally not give relief in your custom tray. Not recorded in the final impression. So in the denture you will be using the steel burr or the carborundum disc to give this. It has to be refined only with the carborundum disc, that is correct. But if you are recording it properly in your primary impression, giving a proper relief in your custom tray up to the depth of the, below the depth of the attachment of the frenum, it is automatically recorded in your impression. Automatically that form comes in your denture. You need not use a burr or a carborundum disc to define it. So make sure that we are recording it in the primary impression stage itself. So here in the labial vestibule you have two muscles, the orbicularis oris and the mentalis. So as I said before, orbicularis oris is a horizontally running muscle. So that is not creating much of a problem, you can cover that muscle. Whereas mentalis is a very strong vertical contracting muscle. So even if you find good depth in the labial vestibule, sometimes you might wonder that it is getting displaced, denture is getting displaced every time. So there you have to record it functionally. You will have to reduce the extension of the labial vestibule in the tray, record it again, it will contract, the mentalis will contract and raise the border molding material up. So there you have to functionally record it by contraction of the mentalis. Otherwise it will push the denture up. So here you see, this is the area of mentalis action. So at rest it is like this, but in contraction it comes here. So the depth of labial vestibule that you have to record should be stopped here and not here. The buccal frenum, again, here also you have three muscles in the buccal frenum, depressor anguli oris, buccinator and orbicularis oris. Depressor anguli oris below the attachment of the frenum. From anterior it is orbicularis oris, posteriorly you have buccinator. So you get a slightly wider relief than your labial frenum. Again, when it is attached to the crest of the ridge, it has to be surgically repositioned. The main muscle is your buccinator. As you go distally in the distobuccal flange, you also have the influence of masseter. So as masseter, when you properly border mold in the distobuccal flange, you can see a small depression or a groove, masseteric groove. That masseteric groove is in the distobuccal border of your lower impression. It is created by contraction of masseter over buccinator. Masseter is a clenching muscle. So if the patient clenches, how you record this distobuccal flange? Same way as in your upper, labial frenum, labial vestibule, buccal frenum, buccal vestibule, you can mold and record. Distobuccal, opening closing is one. That's for your pterygomandibular raphe. You will leave that in the distal border. Apart from that, you should also give pressure downwards, ask the patient to close against resistance. When the patient closes against resistance, the masseter will get contracted over buccinator to give this masseteric groove. So this is how you get your masseteric groove area. It's because of contraction of masseter over buccinator. That's the important question in the entrance, buccinator over masseter, masseter over buccinator. At the time, blindly if you read, you can't remember. But once you see that picture and it is registered, it will never go out of our mind. Buccinator is like this horizontal running muscle and the masseter comes and pushes the buccinator. So sometimes if you have options like that, before you see the options, you decide what is the answer and then look into the options. You will start confusing if you see the options. So next is your retromolar pad and papilla. There are two terms which are used interchangeably, the retromolar pad area and the pear-shaped pad area. Retromylohyoid curtain, that's coming. Retromylohyoid curtain, that marks the posterior limit of your lower denture. So Seashell described it as retromolar pad and Craddock gave it as pear-shaped pad. There are three terms that you have to remember here. So retromolar papilla means it is the area distal to your third molar. With the picture I can tell you. Pear-shaped pad, see this the same thing I will read. Retromolar pad is a soft elevation of mucosa that lies distal to the third molar. Retro means back. So behind the third molar what area you have is the retromolar pad area. Whereas Craddock described it as pear-shaped pad area, this is the area combining the residual scar of the third molar and the retromolar papilla. So after the third molar is extracted, that residual scar plus what is distal to that, papilla that is distal to that is retromolar papilla. Combined will give you your pear-shaped pad. So this is the area of retromolar pad, the glandular area. This is the area of pear-shaped pad, the residual scar of the third molar along with the retromolar papilla. So both are interchangeably used, but what we normally mark in the patient is that retromolar pad area. So boundaries, this area again it rarely resorbs because you have temporalis attachment here. That is the area of the retromolar pad. Again the area of retromolar pad should be outlined before your primary impression stage, so that most of the trace that we have will not include the retromolar pad. So unless we make sure that with the compound we are extending up to the retromolar pad and the distolingual flange. So automatically if you aim for this covering the retromolar pad completely, you will also record the distolingual flange completely. Initial cases you will not know where the retromolar pad is. Try to locate that with a Eosin pencil. If you cannot do it, you call a staff member to help you locate the retromolar pad. So this is again retromolar pad in section. In the submucosa you have the buccinator, superior constrictor, pterygomandibular raphe and the temporalis tendon coming. So this is how it is marked. This is the full stretch of the retromolar pad and this is the anterior 2/3. So in your up to the impression stage you should have complete retromolar pad. Only then in the cast you will have the full retromolar pad to locate where the anterior 2/3 ends. From the record base stage you will have it only up to the anterior 2/3. So lingual frenum overlies the genioglossus muscle. Again it should be carefully relieved. Lingual vestibule divided into three: anterior, middle and distolingual. Anterior vestibule is also called as sublingual crescent area, anterior sublingual fold or anterior lingual seal area. The seal is not only important in your distolingual, it is also important in the anterior lingual area. The middle area, the main muscle will be your mylohyoid, and the distolingual it is also called as lateral throat form or retromylohyoid fossa. So the major portion is your middle vestibule influenced by mylohyoid muscle. Anterior to that is the anterior sublingual crescent area, posterior to that is the retromylohyoid area. The retromylohyoid area is also called as distolingual vestibule or lateral throat form. Anterior lingual vestibule is influenced by genioglossus, lingual frenum and by sublingual gland. Anterior lingual seal you need not know. So where you have the sublingual gland, it overlies the mylohyoid. So as mylohyoid contracts, the sublingual gland will raise up and reduce the depth of your lingual flange. So this is where it is. The sublingual gland overlies the mylohyoid muscle. So as mylohyoid contracts, this gets raised up. So at contraction it is raising up and decreasing the depth of your sulcus, lingual vestibule. The middle vestibule is the largest of the lingual vestibule. It is influenced mainly by the mylohyoid and somewhat by the sublingual glands. So here there is some explanation specifically for mylohyoid. Like you have seen lower dentures, no? Lower denture or your lower impression. The depth of the flange is greatest anteriorly or posteriorly? Posteriorly only the depth of the flange is greatest. You have also seen a complete denture, no? Anteriorly the depth is small. As you go posteriorly the depth is more. But just see this picture. The mylohyoid level of attachment of mylohyoid, posteriorly it is at a higher level. Anteriorly it is at a lower level. So that means your flange should be deep anterior and shallow posteriorly. But what you are getting is contrary to that, no? You might not understand what I am telling also. But again and again you listen to this, as you do your cases you will remember, you will know. First time you do your denture only you will understand this. Dummy dentures you would have made, but that you will not get an idea of how the flange is. Anteriorly the flange is shallow and posteriorly the flange is deep. But whereas you see the level of attachment of the mylohyoid, anteriorly it is at a lower level, posteriorly it is at a higher level. It is quite contrary to the shape of the lingual flange that we are getting. Why does it occur like that? There should be some reason why it happens almost opposite. Posteriorly also, anteriorly also. See, it's because this mylohyoid fibers anteriorly it decusates in between. But as it runs posteriorly, it runs down to the hyoid. So you can also see that in contraction you see anteriorly the mylohyoid fibers are almost horizontal. Whereas at the posterior region, as it contracts, it is only running towards the hyoid bone. So you are able to cover the muscle though it is attached at a higher level posteriorly. Whereas anteriorly, you cannot cover the muscle because it is going to be horizontally acting. So wherever you have a horizontally acting muscle, you can, that's in your, other things we said horizontally you can cover, vertically you cannot cover. It's contrary to that in the mylohyoid alone. When it is vertically acting, you can cover because it is running towards the hyoid bone. Whereas anteriorly it is going to decusate in between, so your denture should lie above that. It cannot go below that. So this level of attachments and things like that can be asked. So depending on how much depth you have below the mylohyoid ridge, the retromylohyoid fossa or the lateral throat form can be classified into class 1, class 2 and class 3. This in your case history also we try to record this. Class 1 is low, that means you have more than ½ inch from the mylohyoid ridge to the bottom of the retromylohyoid fold. You have quite a lot of depth to cover in your distolingual flange. Most favorable. Class 2 is, so this is the lateral throat form. From the mylohyoid ridge to the retromylohyoid fossa, how much depth you can record. When you have less than ½ inch from the mylohyoid ridge to the retromylohyoid fold, it is class 2, slightly less favorable than class 1. When the retromylohyoid ridge and the retromylohyoid fold are at the same level, then it is least favorable. You do not have any depth to record. See, one more easy way to mark this is, because this much complicated, if you see in the patient's mouth, you really don't see the ridge itself, then where do I locate the retromylohyoid fold or the mylohyoid ridge? It's difficult to locate. So what we normally do is, we insert the head of your mouth mirror in the distolingual flange, distolingual sulcus. If whole of the head of the mouth mirror is not seen, it is class 1. If half the head is seen, then it is class 2. If full head of the mouth mirror is seen, then it is class 3. The posterior limit of the mandibular denture is marked by the retromylohyoid curtain. Retromylohyoid curtain is formed by palatoglossus and superior constrictor. This is the distal end of the denture is marked by retromylohyoid curtain. So again, ideally you should have a well defined retromolar pad, blunt mylohyoid ridge, deep retromylohyoid space, low frenum attachment, absence of undercuts, abundant attached keratinized mucosa and adequate alveolar height. So that completes your anatomical landmarks. Impressions I will rush through. This is more important for theory and for your exam viva things, because lot of questions is asked from impressions because you are going to do that in your exam. But for entrance perspective, impressions, not many questions I think you can expect. This is more of a essay type of answer. So we will rush through this and then see the questions. So these definitions you will be knowing. What is the impression? It is a negative replica of the entire denture bearing, stabilizing and border seal area. It can be divided into primary impression and final impression. Primary is for the purpose of diagnosis or construction of a tray. Final impression completes the registration of whatever details you want. It is used as a master cast for construction of the denture. So these are the basic requirements. Objectives of impression making was given by Boucher. 5. Preservation of alveolar ridge, retention, stability, support and aesthetics. So you can classify impression techniques based on the amount of pressure you apply into pressure theory, mucocompressive, minimal pressure theory, mucostatic and selective pressure theory. So selective pressure theory is one of the best theory and what we are following for our impressions. It was given by Boucher. So that's where your concept of stress bearing area, relief area, all those came. You will relieve the areas giving a spacer, and where you want to apply pressure, you will not give a spacer. That is selective pressure theory. Pressure theory means throughout you are going to apply pressure. There is no spacer given. Completely all the areas are going to be pressurized. Minimal pressure means throughout a spacer is given so that you don't pressurize any of the areas. According to the position of the jaw, it can be closed mouth or open mouth. According to the manipulation, hand manipulation or functional manipulation, functional movements. So these are the steps. First you examine, select the impression material, tray, operator position, patient operator position and select the impression technique. Make your primary impression, construct the primary cast, fabrication of special tray, border molding and final impression. These are more for your theory that you, when a question like impressions in complete denture is asked, you have to explain all the 10 points. Examination, selection of the material. How do you classify impression materials? Based on viscosity, mucostatic or mucocompressive. So what material you use for making impressions? Denture. Impression compound is a mucostatic or a mucocompressive material? Mucocompressive material. What about alginate? Alginate can be used as a primary impression material. It's a mucostatic material or mucocompressive material? Mucostatic. Yes, it is mucostatic only. So based on viscosity you can classify, based on setting reaction you can classify, based on elasticity you can classify. For primary impression materials used are impression compound, then what else can be used as a primary impression material? Not plaster of Paris is your type 2 plaster which you use for impression plaster, can be used, yes, it was used before. Then like base that cannot be used as impression material, no? It can be used as a record base. Alginate can be used as a primary impression material. Then elastomers, putty of addition silicone can be used as a primary impression material. Some material which will stay in the stock tray can be used as a primary impression material. Exception is your alginate, when you have to mold the borders with some other material if you want to extend and then make impression with alginate. For border molding, what are the materials? Green stick impression compound. Then what else can be used? Impression materials fresh from learning from underserviced Skinners. What are the different impression materials available? Names? இது என்னன்னே தெரியல எல்லாமே அங்க இருக்கா சொல்லுங்க அதுக்கு தானே போட்டு வச்சிருக்கோம் நம்ம அதை பார்த்தா சொல்லுவோன்னு names of materials you don't say, you know certainly some zinc oxide eugenol, yes. Then elastomeric impression materials. Zinc oxide eugenol is a primary impression material or a secondary impression material? Why is it a secondary impression material? Generally secondary impression material or final impression material should be free flowing on the confines of your custom tray. So it doesn't have body on itself to stay in a stock tray. So it cannot be used as a primary impression material. Primary impression you can use impression compound, yes you can use impression plaster, alginate, putty of addition silicone can be used. For border molding you can use green stick compound, but more preferable is your elastomers. Again, addition silicone, you can use either putty or heavy body. You can use polyether of elastomers for bottom molding. For final impression, zinc oxide eugenol impression paste, then elastomers, but you cannot use putty or heavy body. You have to use either medium body or light body. Now, very important for Viva. These things are only asked in final year Viva. The material part I will skip. This one alone I will tell because you may not read this. What is the difference between your impression plaster and regular plaster? What do you add? Setting time should be faster. You cannot wait for 30 minutes definitely. So you will add an accelerator. Yes, then you have used dental plaster, no? Some modification of dental plaster only can be used as an impression plaster. It was initially available, but now we have better alternatives for mucostatic impression like your light viscosity materials. So we no more use this. But for theory purpose, you need to know what is the difference between an impression plaster and a regular plaster. Modifiers added are potassium sulfate, which has two purposes. One is acceleration, the second is reducing the setting expansion. So because the acceleration might be too fast, you also add a little of borax to counteract the acceleration in setting caused by potassium sulfate. Alizarin red to give some color to the material. Starch and gum tragacan. Gum tragacan is used as a binding material. Starch is added. Why is starch added? Because you make your impression with impression plaster, ultimately you are going to pour, what you will pour into it to make a cast? Either plaster or stone. So both are made of same material. How will you separate it? So that's why they add starch to the impression material, so that after the material sets, after your cast sets, you will put that into water. So the starch will absorb water and swell, and you can remove your cast from it. That is why starch is added to impression plaster. The modifications are potassium sulfate, borax, some coloring agent, binders and starch. Alizarin red is a stain, then basically it is a dye stain now. Growth determine பண்றதுக்கு. So they அது வந்து stain inject பண்ணிட்டு அதை read பண்ணுவாங்க. அதுக்காக it's used as a stain. It's not going to do anything with the growth. So அதே stain dye தான் இங்கே யூஸ் பண்றாங்க just for color. So impression waxes can also be used, which we did not list there. It is not a regular impression material, but it can be used in some area. Where is it used? That just now we described, no? Fluid wax. So it is used as a corrective impression material for some areas in the impression, not as a regular impression material. Zinc oxide eugenol, yes, it is used as a secondary impression. Agar also can be used, but because of the laborious equipment that is required, we no more use agar. Alginate can be used both as primary and final. Though final, it is not preferred. Elastomer, yes, it can different viscosities for all the procedures from primary impression, bottom molding, final impression. It is preferred material. So mainly we use the addition silicone and polyether. Impression tray, how you classify them? The parts of the tray: body, handle and vault for the upper, floor and flanges. Some names of trays like Cox, Denture, rimlock tray, stock other crawl tray, McGowan Winkler tray for flat lower ridges. So impression techniques, it is classified into mucocompressive, mucostatic and selective pressure. Mucocompressive was given by Green brothers. What they state is all the impression should be made at a compressive stage. So primary impression is made with compound, the secondary also is made with compound in closed pressure. The patient will close. Closed mouth impression means You will make your occlusal rims, the patient will bite on the occlusal rims while making impression. So always under pressure. So amount of resorption is more. So that's why this technique was not continued. Excess pressure leading to increased resorption. Mucostatic is exactly the opposite of it, that you don't give pressure on any of the areas. So complete spacer, under extended borders. It is based on Pascal's law, that in a closed environment, wherever any one area you apply some pressure, it is going to be equally distributed throughout the area. So retention here is achieved by accurate tissue adaptation on that minimal area. It does not even extend to the border. So complete spacer will be given, no border molding is done, direct impression is taken. So advantage was claimed as tissue health and preservation, but disadvantages, obviously the retention will be less in this. So then came your selective pressure theory by Boucher. He only divided this areas into stress bearing, relief areas, limiting structures first, so that we understand, and patient wise we divide what type of spacer we need to give for this patient and type of impression also. So preliminary impression, when you are recording it, make sure you record the sulcus depth and width, all the required anatomical landmarks up to the maxillary tuberosity in upper and retromolar pad in the lower. How you select the trace? How do you select the trace for primary impression? The trays are available in different sizes, 0, 1, 2, 3 and 4. How do you select that this size tray I will make the impression? How you will know that it will cover? So you keep the first, U1 first. It's not fitting, you will keep it out. Then you will try 2, keep it out. Then try 3. That's not the right method. Then you are contaminating all the trays. Unnecessarily a whole set has to go into autoclave again, though you are not doing it. But the actual procedure is to autoclave the trays. No? So to minimize that, the better technique is you have to use a divider. And some companies, along with the tray, you also get that gauge, like paper gauge they give, through which you can measure the distance between the tuberosity for the upper, measure the distance between the retromolar pad for the lower. Place it in the depth of your tray. In the floor of the tray you place it. So approximate size of tray you will get. In that way, maybe one size this side or that side you might go wrong, but mostly this is correct. So you have to use a divider to measure the space between the height of the tuberosities and the retromolar pad, place it in the tray and then select your tray. When you are selecting your tray, the space between the tray and the impression material should be about 5 millimeters. Tray and the tissues for the impression material should be 5 millimeters. Primary impression materials are compound, alginate and elastomers putty. So this is how you measure. You will measure it between these two and place it here. So approximate space, definitely you will not go wrong. So some trays you have a marking like this here. So approximate area of first molar also you can select and use it here. Borders are sometimes marked. In alginate you can mark the borders and then pour a cast. So if required you can extend your tray outlines and then make your impression. For the lower again, select your trays, make the impression. So checklist again, what all are required landmarks should be recorded. You will make a primary cast out of it. In the primary cast again check whether all the required landmarks are recorded. You will make 3 markings, one to the full depth of the sulcus, the second marking for the special tray, the third marking will be for your spacer. You make a custom tray. The relief for areas where you don't want to give pressure. So you can either relieve the impression tray or you can relieve the denture base. Normally we use it in the impression tray itself. We place a wax spacer or you can trim the tissue surface of the tray. But most commonly used technique is placement of the wax spacer. Stoppers 2 into 2 millimeters, sometimes we also say 4 into 2 millimeters, rectangular shaped stoppers. In the area of canine and first molar it is placed. Materials for custom tray are your self-cure acrylic, shellac, tray compound, old dentures, vacuum form trays. Light cure trays can be used. So properly finished tray, proper extensions, given relief for the frenum attachment and uninterfering handle. The handle will be about 10 to 15 degrees tilted in the upper, for the lower it should be straight. So additionally you can also have two posterior handles in the lower because invariably if you don't have a good ridge it will, so you can have for additional support you can have two posterior stops, very advantageous when you are using it. You can fabricate it by finger adaptation methods, tray sprinkle on or tray forming mold method. Border molding, for each area you have specific technique to border mold. You can either use a incremental border molding technique or a continuous border molding technique. Incremental you use green stick compound, section wise you will do, whereas continuous means you will use elastomers, either polyether or addition silicone. So these are the muscles that are surrounding whatever we described now, no? This area, these muscles will act. So you have to give space for all these muscles to contract. Completed border molding. Border molding materials are these. What method you can use? Functional, manual, combination, segment by segment or one-step border molding. So individual areas, how you border mold. Generally lip is upward, outward and downward. So again what muscles you have. This is a repetition of what we saw in anatomical landmarks. There itself I had informed you how you have to record distobuccal flange, so everything is just complete here. Again for the mandible, labial frenum, labial vestibule, buccal frenum, buccal vestibule, distobuccal area you ask the patient to close against resistance. For the lingual vestibule you ask the patient to put the tongue out, hold and touch up and left to right. Fine impression. S-shaped curve. It's mainly because of the mylohyoid muscle. Mylohyoid muscle, it looses and turns as it goes distally. Adanaல தான் S-shaped. This is your finished impression in elastomers. Final impression materials. You will bead and box. The beading boxing can either be done with wax or it can be done with plaster pumice mix. That's all. After some questions we'll break. Questions, that's also difficult. Any guesses? All want to go by that? It is 22.96. 45 is for the dentulous periodontal ligament area. Mean denture bearing area in the edentulous mandible is 12.25, less 12.25. Sometimes you know you can exclude and find your answer. That is also a way of finding in exams. Dentulous? That is 45. No, that's not a denture bearing area, complete periodontal ligament. So it will be almost the same for maxilla and mandible. Only when it becomes edentulous, you calculate the area of the palate also. Combined periodontal ligament with this 45. Half only is seen. What is the problem? Anyways, you can read it. Flabby hypoplastic tissue occurring along the border of the denture is called flabby hypoplastic tissue that occurs along the border of the denture. In many cases, denture wearing patients, you will see that. Epulis fissuratum, that is also called as denture irritation hyperplasia. Particularly, it occurs along the border of the denture. Average masticatory load on natural teeth is 44 pounds. Complete denture patients, the masticatory load during chewing is about 4 13 to 16 pounds. At 44 pounds, other words it is 20 kgs. 13 to 16 pounds, in other words, is 6 to 8 kgs. Sometimes that conversion also we need to know. Maximal bite force in complete denture varus is less than that of natural teeth by 5 to 6 times. These things you just have to learn. So muscle tone decreases by how much percentage in old age? Decreases, of course. How much percentage? 20 to 25 percentage. D is the answer. After these values, I expect you to answer. Values I know you cannot answer, so we will just give the answer directly. Total time during which the teeth is subjected to functional forces of mastication and deglutition during an entire day amounts to approximately, in many books this is given, many MCQ books also I have seen this question. Throughout the entire day, the time when the teeth are going to be in contact, functional forces, mastication and deglutition. It is 17.5 minutes. Actually, during chewing alone, if you see the functional forces contacting, teeth contacting will be for 5 minutes. One chewing stroke is for 1 second. Like that you can list many numbers only for this chewing cycle and contact. Maybe you will have to, wherever you find tables in the book. It's easy, MCQ, those who are setting also, they don't go and read into a few people only will do that. Otherwise, whatever is easily visible, they might choose. So tables don't miss. They give a table for this. Deglutition, how much time it takes. Each chewing stroke, how much time it takes. In old age, which of the following can happen? Drooping of upper lip over maxillary teeth, heloptosis, both A and B, and none of the above. Heloptosis can happen. What is A? Both are same only. So it is C. Of the following types of denture stomatitis, all of them show microbial plaque accumulation except type 1, type 2, type 3, and none of the above. You know what is denture stomatitis, no? Denture wearing, you will get those irritation, inflammation on the palatal surface. It is of 3 types, type 1, type 2, and type 3. Type 1 is, it shows pinpoint hyperemia. Type 2 you will have diffuse hyperemia. Type 3 you will have granular eruptions. So which of them shows microbial plaque accumulation? Except A. So type 1 you don't have. Other types, type 2 and type 3 you definitely have. Diffuse erythema is seen in which of the following types of denture stomatitis? Type 1, 2, 3, 2. Diagnosis of candida. Most often if you see in denture stomatitis, along with that you can also find candida in that. Diagnosis of candida associated denture stomatitis can be confirmed by the presence of more than or equal to 30 colonies, 50 colonies, 70 or 100. 50. But even if these values, if I ask you next week, maybe you will not be able to answer. Values you have to repeatedly see, or in whatever book you are reading, you start writing it side. Small, 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 small. Whenever you are turning the page, that should be visible. Or stick some on the sticky note and then write. Overextension of mandibular denture base in the distofacial area will cause dislodgement of the denture during function due to the action of masseter. Mandibular and the distobuccal, it is masseter. Masseteric notch occurs due to, now you know this. Buccal shelf area in the mandibular arch is the primary stress bearing area because of all of the following except vaccinator fibers are parallel to the denture borders. Location is buccal to the crest of the ridge. Presence of underlying compact bone. Almost horizontal location. You have to give me answer for these. Buccal shelf is the primary stress bearing area. What are the reasons for it to be called as a primary stress bearing area? Vaccinator fibers, location of buccal to the crest of the ridge. Presence of underlying compact bone, almost horizontal location. You all can also answer because these are from the class only today. Try to answer. You can go wrong, no problem. Idima? Buccinators are parallel except, so buccinator runs? It runs parallel only, so it is not the answer. So one of it should be wrong. The buccal shelf area has compact bone. It has a flat surface, almost horizontal surface, so that the forces will fall perpendicular to it. Buccinator fibers are parallel. So location is just because it is buccal to the crest of the ridge, you cannot call it as a stress bearing area. So B is the answer for that. The crest of the maxillary residual ridge is a primary stress bearing area for the following reasons except underlying compact bone, fibrous connective tissue, keratinized epithelium and glandular tissue in the submucosa. You don't have glandular tissue on the crest of the ridge, you have it in the palate only. The palatine aponeurosis, which is the anterior portion of the soft palate, is composed mainly of tendons of the muscle. Tensor palatine. Okay, next also you will be able to answer. Posterior vibrating line is at the junction of aponeurosis of tensor palatine and muscular portion of soft palate. Which of the following about posterior palatal seal is false? Anterior vibrating line is marked using Valsalva maneuver. Posterior vibrating line is on the soft palate. Anterior part of the soft palate contains abundance of muscle fibers, so C is wrong. Class 3 soft palate is associated with which type of palatal configuration? Flat? Yes, high V-shaped palate. Retromolar pad contains the following except adipose tissue, glandular tissue, buccinator fibers and superior constrictor fibers. It doesn't contain adipose tissue. Typical S shape of the mandibular lingual flange border is due to the action of myelofibers. You got the answer in between. No? Class 2 type of soft palate, the angle made between the hard palate and the soft palate is 45. Class 3? Class 3 turns acutely, but the angle 70. Because if you say class 1 is almost horizontal, the angle will be less. Class 2 angle will be more. Class 3 angle will be still more. So that kind of English confusion we can have. It turns acutely, we might mark it as 15. 70. 70 class 3. Retromyelloid curtain is formed by palatoglossus and superior constrictor, not pterygomandibular lattice. Palatoglossus and superior constrictor. Mandibular labial frenum is influenced by which of the following muscle? Orbicularis. Which of the following regarding hard palate is true? Anterolaterally it contains adipose tissue, posterolaterally glandular, both A and B are false, both A and B are true. D, both A and B are true. If a complete denture patient has genial tubercle at the level of crest of the mandibular ridge, the denture base can cover them, should not cover them, should cover them and relief is not necessary. Cover and relief is a must. Cover and relief is a must. Fovea palatine are situated anterior to anterior vibrating line, posterior to posterior vibrating line, not fixed. Is the same thing I have read in one more thing that it says it's on the soft palate, it's on the hard palate, junction of the hard and soft palate. And not fixed. But there I just got little confused because some books say that it is distal to the junction of the hard palate and soft palate. So maybe that means it is on the soft palate. Luck should be that such kind of questions should not come in your exam. Controversial questions. Teeth arrangement in neutral zone will enhance the retention, support, stability or occlusion of the denture. Stability, because neutral zone is the zone of minimal conflict between your lip and cheek muscle on one side and the muscles of the tongue on the other side. For improving support of the mandibular denture, it should cover anterior 2/3. Emergency retentive force in complete denture is, this is one question which gets repeated in the MCQ books, atmospheric pressure. The ability of the denture to resist vertical movement is retention. In constructing a custom tray to use with polysulfide, not only because that MCQ read like this, but it can be for any impression material. The thickness of the base of your custom tray should be even throughout to allow for shrinkage, expansion, dimensional accuracy or ease of handling the tray. Dimensional accuracy. That's why they always say, when you're making a special tray, it should be even 2 millimeter thickness. To make an impression of flabby or hypoplastic tissue, it is necessary to use wax as an impression material, assure intimate contact of the impression material with the tissue, use heavy body polysulfide in order to displace the tissue, use a close fitting tray to help mold the tissue into desired position. In your case, when you make your special tray, sometimes you can have anterior flabby tissue. If you show, maybe your staff will advise you to modify the tissue design. They might ask you to give double spacer, or they might ask you to give multiple holes in the tray, so that you make that portion of the impression without any pressure. Flabby tissue is a movable tissue, you don't want to apply pressure. So definitely using heavy body is wrong. Using a close fitting tray also will do that, it will pressurize that area, that is wrong. Use wax as an impression material, apart from wax you can use many other materials also. So you have to assure that you intimately contact the tissue. That is correct. B. By excluding you can find out. So what we normally do is, we make that section of the impression alone with a mucostatic impression, placing 2 spaces. Tissue health and preservation is achieved best using which of the following impression techniques? Mucostatic, selective pressure, mucocompressive, open mouth. Actually, it is not true. Selective pressure only is correct. It's best, we don't say it is best because some areas you have to slightly give pressure as a part of stimulation for the blood supply. You're not going to pressurize any of the area, the blood supply is totally going to get reduced and it is going to act in reverse only. So selective pressure is a better technique in terms of tissue health and preservation. Interfacial surface tension is the main retentive force in mucostatic, selective pressure, mucocompressive, open mouth technique. Mucostatic. Minimal flange technique is a concept in mucostatic, selective pressure, mucocompressive, open mouth. Okay. Mucostatic only, minimal flange. You also sometimes use metal flanges, that also can be asked. Metal flanges but not extending to the border. Mucocompressive impression or definite pressure impression aims to achieve tissue preservation, optimal retention, patient comfort and tissue tension. Minimal pressure technique is the other name for mucostatic, minimal pressure, no? That's definitive pressure means mucocompressive. Mucostatic impression technique was given by Richardson. If you can say Richardson, that's very true. Richardson only actually gave, but it was popularized by Page. So if both the names come, then you have to read the question properly. It was first given by Richardson. It was popularized by Page. Because Richardson is not there, no confusion at all, directly you can write Page. Selective pressure impression technique was advocated by Roach. Mucocompressive? Green. Physical laws of hydrostatics and Pascal's law were associated with mucostatic. Most common cause for poor posterior parietal seal is underextension. Which of the following angles formed by the Frankfurt's plane to the horizontal plane when the patient bends down records the posterior parietal seal in the best way, 30 degrees. This was one of our all India questions. What is Frankfurt's plane? It's not a soft tissue point, it's a cephalometric. So bony landmark you can say. Side of nose, ala to tragus is not Frankfurt's horizontal plane. That is Camper's plane. It's between orbital and chorion. Fluid wax technique to record the posterior parietal seal uses which of the following waxes? Iowa, correcta, all. Apart from that, adaptol also will come. In conventional technique of recording posterior parietal seal, which of the following is true? It's deepest in the midline raphe region. Midline raphe is scraped to a depth of 0.5 to 1 millimeters. Either side of the midline it is scraped 0.5 to 1 millimeter. Midline to the depth of 1 to 1.5 millimeters. Midline, in the midline raphe region it is the minimum, so it is 0.5 to 1. B is correct. On either side it can be scraped up to 1 to 1.5 millimeters. Extended palatal technique was given by Silverman. Extended palatal technique is recorded about, it's not from posterior vibrating line, it is from anterior vibrating line. Beading of the final impression using plaster pumice mix is done at what level inferior to the border? 3 millimeters. Though 2 is also correct, but book says 3 millimeters. While making final impression, tray should be seated first, anteriorly, posteriorly, and posteriorly simultaneously, depending on the operator's choice. Normally when you are making your impression, which one you will place first? Posteriorly first. That's what we learned for alginate impression in a stock tray, that you have to keep posteriorly first and then press anteriorly so that the excess will flow out anteriorly and not posterior. But for final impression, because it is in the confines of the special tray, and it is also easy to position the frenum and place it correctly, it is anterior to posterior. So it is first placed anteriorly. Slightly different. Otherwise, generally when you are making impressions, always we say posterior to anterior because it should not gag, flow inside and gag for the patient. Custom tray means we already control the material, so we will not put that much excess, and you also have relief holes for the excess material to flow out. So it is anterior to posterior. Distolingual extension of mandibular impression is limited by is also part of your retromyloid curtain. The same thing in different terms it can be asked. Retromyloid curtain is going to form your posterior most limit. In the same thing only they are asking. Distolingual extension is limited by superior constrictor. So whatever ways they ask, the answer is going to be the same. So we shall break now.